Primary cardiac tumors. Andrew Ferguson. UIC. January 3, 2008. Agenda: Primary tumors treatment/prognosis, clinical manifestations. Systemic findings. Embolic phenomena. Cardiac manifestations. Diagnostic evaluation. Physical examination. Echocardiography. Röntgenography. Cardiac catheterization. MRI. PET. Primary tumors. Benign. Benign or malignant. Malignant. Treatment/prognosis. Observation. Excision. Chemo/radiation texas. Recurrence. Cardiac tumor occurrence 0.002 to 0.3% incidence in autopsy series. Metastatic involvement of the heart is 20 times more common than primary lesions. Majority are benign, till the 75%. Clinical presentations. Systemic. Symptoms. Biomarker abnormalities. Embolic phenomena. Cardiac manifestations. Mechanical issues. Conduction disturbances. Systemic findings, non-specific signs/symptoms, laboratory findings. Fever, cachexia, malaise, arthralgias, Raynaud's, rash, clubbing. Constitutional symptoms. Laboratory findings. Hypergammaglobulinemia, elevated ESR, thrombocytosis, thrombocytopenia, polycythemia, leukocytosis, and anemia. Etiology of systemic findings. More often seen in myxomas. Synthesis and secretion of IL-6. Inflammatory cytokine which induces the acute phase response. Prior to advanced imaging, not unusual for alternate diagnoses of collagen vascular disease, infection or non-cardiac malignancy to be made. Embolic phenomena, tumor fragments or its adherent thrombus. Manifestation depends upon tumor location. P. Can lead to pars/cor-pulmonal, systemic infarct, ME, CVA, etc. Vascular aneurysms and visceral hemorrhage. Multiple emboli can mimic systemic vasculitis or EA. Metastasis may help lead to diagnosis, i.e. skin biopsy. Cardiac manifestations. Obstruction of circulation. Interference with valve function. Direct invasion. Decreased myocardial contractility. Conduction disturbance, block and arrhythmias. Tamponade. Obstruction of circulation. Symptoms correlate with location, i.e. left atrial tumors often mimic symptoms of MV disease by obstructing avenue flow or causing MR, prolapse. To differentiate from other cardiac diseases, tumor symptoms tend to have the following: sudden onset, intermittent occurrence, positional dependence, diagnostic evaluation. Purpose is to guide therapy. Location, size, malignancy, physical exam, echocardiography, röntgenography, cardiac catheterization, CT, MRI. Physical exam again, dependent on location. LA tumors, RA tumors. Pulmonary congestion, S4, loud, widely split. S1, diastolic murmur, Mr. Murmur, tumor plop. RA tumors. Right-sided congestion, diastolic murmur, TR, tumor plop. RV tumors. Right-sided CHF, SEM, presystolim and diastolic rhombel, S3, delayed P2. Differentiate from PS. LV tumors. SEM, positional changes of murmur and BP, other findings similar to as, subaortic stenosis, HOPE, etc. Differ from PSDT, rapidly progressive SXS, no post-stenotic dilatation and no ejection click. In the old days, Roentgenogram's cardiac catheterization. raised the suspicion, but rarely diagnostic. Cardiac catheterization was relied upon to aid in diagnosis of cardiac tumor when suspicion was high. Alternate imaging modalities have helped remove this potentially risky method. Should still be used when non-invasive eval did not fully define location/attachment. All cardiac chambers have not been visualized. Coexisting cardiac conditions are suspected and delineation with cath may change the surgical/treatment approach. Examples: radionuclide imaging inferior to echo/CT MRI. Gated blood pool identifies atrial, ventricular and intramural tumors. Radionuclide ventriculography has relatively poor resolution compared to echo or contrast angio. Echocardiography 2D echo has become initial study of choice. M-mode can still be helpful. Doppler useful for hemodynamic eval. T often indicated for full visualization. Tumor contour, cysts, calcification, stalk. CT most useful when MRI is not available. Advantages: tissue discrimination, tumor extension, attachment, reconstruction in any plane, evaluation of involvement of pericardial and extracardiac structures. MRI preferred over CT when available. In addition to that gained by CT, MRI, T1 and T2 weighted sequences reflect the chemical microenvironment within a tumor. Malignant versus benign tumors. 75% of cardiac tumors are benign. Malignant tumors more likely to have distant metastases, local mediastinal invasion, evidence of rapid growth, hemorrhagic effusion, precordial pain, right-sided location, combined intramural and intracavitary location, extension into pulmonary veins, TTE example. Benign tumors. Myxoma most common primary cardiac tumor. 30 to 50% of all cardiac tumors in path series. Mean age 56 in sporadic cases, age 3 to 83. 70% female. 86% occur in left atrium. 90% are solitary, intracavitary and located in atria. Cardiac myxoma classic triad, 20% asymptomatic. Obstructive cardiac symptoms. Embolic phenomena. Constitutional symptoms. 20% asymptomatic. CT left atrial myxoma. Can you find it? Uncommon location, -10%. Atrial myxoma histo. Mucopolysaccharide matrix and vascular channels with myxoma cells. Microscopically, myxomas have an abundant mucopolysaccharide matrix and vascular channels with varying numbers of distinctive stellate or plump myxoma cells. Left slide. Tumor-associated thrombus, degeneration, hemorrhage, calcification, inflammatory infiltrate, basophils, or superinfection may lead to an incorrect diagnosis of mural thrombi or endocardial vegetations. Right slide. Similar cardiac presentation of sarcomas have been rarely described and may present initial diagnostic confusion. Treatment: surgical resection is required. Operative mortality less than 5%. High risk of embolization. Other CV complications, like sudden death. Operative mortality less than 5%. Generally curative. Cardiac transplant considered for multiple recurrent myxomas, occurring in 5%. Papillary fibroelastoma. Second most common primary cardiac tumor of adults. Some synonyms: giant lamellar excrescence, papilloma of valves, myxofibroma, Myxoma of valves. Hyaline fibroma. Fibroma of valves. Clinical features greater than 80% are found on heart valves. Mainly left-sided valves. Account for 75% of all valve tumors. Men and women affect equally. Mean age 60 years at diagnosis. Multiple tumors in 9% of patients. Clinical features count. Symptoms usually due to embolization of either tumor or thrombus. Most commonly CVA/tear. Also angina, ME, SCD, CHF, syncope, or systemic/pulmonic embolic events. Up to 30% are asymptomatic and diagnosed incidentally at time of an echo, cardiac surgery or autopsy. Histopathology: benign endocardial papillomas. Characteristic frond-like appearance. Mean tumor size 9 mm, range 2 to 70 mm. Core of loose connective tissue. Rich in glycosaminoglycans, collagen and elastic fibers. Fine meshwork of smooth muscle cells. This core is surrounded by endothelium. Papillary fibroelastoma. Treatment: surprisingly no evidence. Surgery definitively indicated in patients who have had embolic events with highly mobile or large, greater than 1 cm, tumors. Some suggest careful observation is acceptable for asymptomatic patients. Recurrence after surgery has not been reported. Lipoma rare, 3% of primary cardiac tumors, predominantly adults. Occur in the subendocardium, myocardium and subepicardium. Symptoms related to local tissue encroachment, arrhythmia, heart block, and sudden death. Histopathology: circumscribed, spherical or elliptical mass. Composed of mature adipocytes. Differ from lipomatous hypertrophy of ears. Usually encapsulated. No brown fat cells. No myocytes found. Treatment: require resection due to the symptoms they cause and their progressive growth. Lipomatous septal hypertrophy. Not a true tumor. Exaggerated growth of normal fat in ears. Up to 2 cm in thickness. Seen in elderly and obese people. Only consider surgery if symptomatic. Atrial arrhythmias. Heart block. Rhabdomyomas: primarily pediatric, usually age less than 1 year. Highly associated with tuberous sclerosis. Found on ventricular walls or avenue valves. Infrequent symptoms of obstruction and arrhythmias. Usually regress spontaneously. Fibromas: second most common pediatric tumor, rarely also occurs in adults. Usually arise in ventricular muscle. Heart failure due to obstruction. Interference with valvular function. Myocardial dysfunction. Treatment: symptomatic tumors are resected. Very large tumors may require resection. Teratoma: obviously a pediatric issue, arise within pericardium. Benign in nature but cause drastic complications via tamponade. High risk of death in utero or after birth. Requires fetal excision or C-section and immediate operation. Angiomas: extremely rare benign proliferations of endothelial cells. Generally found incidentally, but can cause symptoms commensurate with their location. Surgical resection if symptomatic. Paraganglioma: extremely rare. Arise from chromaffin cells, mainly in atria. Majority produce catecholamines. Positive biomarkers similar to FeO. 20% of patients also have extracardiac tumor. Surgical excision is definitive treatment. Mesothelioma can be both benign and malignant. More commonly arise in the pericardium, also rarely arise in the avenue node. Pericardial mesothelioma. Likely malignant. May produce tamponade. Resection is treatment of choice, but remains poor prognosis if malignant. Avenue node mesothelioma. benign. May produce heart block and sudden death. Malignant tumors. Sarcomas constitute most of all malignant tumors. Overall, second most common cardiac tumor. Virtually all cell types have been reported. Clinical presentation depends on location, rather than its histopathology. Angiosarcoma composed of malignant cells that form vascular channels. Predominantly in the right atrium. Rhabdomyosarcoma constitute 20% of all cardiac sarcomas. Mostly adults, also described in children. Multiple sites are common, no site predilection. Fibrosarcoma composed of spindle cells. White fleshy tumors which infiltrate the myocardium. May have extensive areas of necrosis and hemorrhage. Leiomyosarcomas spindle-celled, high-grade tumors. Arise in the left atrium. High rate of local recurrence and systemic spread. Treatment and prognosis. Generally, sarcomas proliferate rapidly. Death usually follows from widespread myocardial infiltration, obstruction of blood flow, distant metastases. Treatment of choice is complete resection. Most develop recurrent disease. Median survival typically 6 to 12 months. Chemotherapy in small studies has not shown survival advantage. Path features predict better prognosis. Left atrial origin. Low mitotic count. Absence of necrosis and metastasis. Primary cardiac lymphoma. Very rare. Typically non-Hodgkin type. Mostly occur in the immunocompromised. Presentation. Progressive heart failure. Chest pain. Tamponade. SVC syndrome. Characteristics can be multiple, firm white nodules. Can be fish flesh homogeneous appearance. More than one cardiac chamber. Pericardiac effusion is common. Histopathology mostly B-cell tumors. Histologic types. Well-differentiated B-cell. Follicular. Diffuse large cell. Undifferentiated Burkitt-like. Lymphoma cells surrounding and infiltrating myocytes. Treatment and prognosis. Small series has demonstrated a 38% complete response with systemic therapy, though question its duration. Otherwise poor outcome is expected.